Good morning. The committee will come to order. For more than a decade, Congress has had to step in and prevent Medicare from cutting physician payments. The time has come for the temporary patches and trend of uncertainty to end. Now Congress must move a permanent repeal of the SGR physician payment formula, which will bring some security to providers and the millions of seniors who rely on Medicare for their health care. Today's markup is the first step toward a permanent solution to ensure seniors access to high-quality medical care, a priority for members on both sides of the aisle. This important work came from many draft frameworks and strong feedback we received in a bipartisan collaboration with lawmakers of this committee and the Energy and Commerce Committee. The bipartisan legislation we have before us today is a result of draft language and feedback from our collaboration with the Senate Finance Committee as well. I'd like to thank the members and staff of the Ways and Means and Senate Finance and Energy and Commerce Committees for all their hard work, members of both parties and their staff. I'd also like to recognize our legislative counsel, Jessica Shapiro, and the rest of the team who've worked tirelessly with our staff to produce this bill. This legislation today provides stability for physicians so they will no longer face massive cuts, but also begins the process of improving how we pay for medical care to focus on positive outcomes and new innovative treatment options. Importantly, the bill gives relief from the current multiple physician incentive payment programs and begins to eliminate duplicative requirements. The bill also provides real incentives and a clear pathway for physicians of all types to begin to break down the roadblocks that keep them from implementing new models of providing care. We're taking action today because of the hard work of members on a bipartisan basis who've kept this issue on the front burner. We have a real opportunity to act as soon as possible because the Congressional Budget Office has lowered the estimated cost of replacing the SGR to just over $116 billion over 10 years, more than half the cost 2 years ago. And because of this lower score, we're able to provide modest increases as part of this proposal in the first 3 years. But we must be careful. Though the score is the lowest ever, it still must be paid for. And I'm of no illusion that finding pay-fors will be an easy task. It will be very difficult, which is why we must keep the cost low, not just to make this more likely that it will pass, but also to ensure limited taxpayer dollars are spent wisely. I look forward to working with the members of this committee to continue to improve this product. This legislation reflects a wide range of perspectives, and that's why I'm pleased that it's supported by nearly 50 different groups, including the American Academy of Physicians, the American Association of Nurse Practitioners, the American College of Radiology, the American Medical Association, the American Osteopathic Association, American Society of Clinical Oncology, Americans for Tax Reform, California Medical Association, Prescriptions for a Healthy America, the National Coalition on Healthcare. And without objection, I'd like to request that these and all the letters of the support groups that we've received be submitted for the record. We're taking an important step today towards certainty. Our actions today move us one step closer to our goal, repealing the physician payment formula and placing security and stability into the Medicare program millions of seniors rely on. And before I yield to the ranking member for any statement he wishes to make, I ask that all member opening statements be included in the record. And without objection so ordered, Mr. Levin is recognized.
Thank you very much. I have a longer statement. I ask that it be submitted for the record.
Without objection.
So let me just briefly summarize it. This is a major effort of reform. I think for any of us who have tried to work through the present system, whether we're physicians, patients, or families of patients, I think all of us would join together in determination to change the payment system and its structure. And so this is a bipartisan, bicameral effort to do so. It builds on the work of Energy and Commerce. It builds, Mr. Chairman, on our work with Senate Finance and the work within our own ranks. On your side, there has been much activity, as there has on our side. Many members have been vigorously active on this issue for a long time. I think one who has been especially active is Representative Allison Schwartz. And I think for you today, this is a day of the beginning of fulfillment. I look down the row and see our colleague Ron Kind and his efforts, and all of those as you go down the road, ending with Jim McDermott, Mr. Rangel, who as chairman was concerned about this. I think I want to join you in thanking also the Office of Legislative Counsel, the Centers for Medicare and Medicaid Services, the CBO, the CRS. So this is much more than a fix. This is an effort to create a new framework for physician payment in Medicare. It's going to provide, if we can perfect it, stability and certainty. And essentially what we're going to do is replace, hopefully as soon as possible, a flawed structure with a much improved one. So let me just say a word. It's so important that we do this and do it right that we're going to have to pay for it. And you mentioned the cost. It's now reduced, but it's still, I think the latest estimate is $117 billion. I think we have to find a way to do that so that we do it responsibly and we don't hit beneficiaries who already bear a substantial burden. And let me close with one other comment, because today we're going to, in terms of SGR, provide for a 3-month fix. It's now part of the budget bill. What we have not been able to do, Mr. Van Hollen and I went before the Rules Committee yesterday, if we're going to do a 3-month so-called fix for SGR, we should have made sure that we also had that kind of addressing of the problems facing the unemployed people in this country, 1.3 million of them who are going to lose their unemployment insurance entirely on December 28. So I deeply regret that decision by the majority party. We're going to have today a vote on a bipartisan product. I think it's more than saddening that we cannot do so with the bill that's going to come up today, not only to make sure that there isn't a 25% cut for physicians, but to take steps to make sure there isn't a 100% cut for the unemployment insurance of 1.3 million people. I yield back.
The committee will now proceed to consideration of H.R. 2810, the Medicare Patient Access and Quality Improvement Act of 2013. Without objection, the bill will be considered as read and open for amendment at any point. On behalf of Mr. Levin and myself, I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of amendment. I'll now turn to Mr. Brian Sutter, Staff Director for the Health Subcommittee, to provide the technical description of the amendment in the nature of a substitute, and I ask that members hold their questions until after his presentation. Mr. Sutter.
Chairman Camp, Ranking Member Levin, members of the committee, thank you. I'll summarize the provisions of the Chairman's amendment in the nature of a substitute. The first section contains the short title, which is changed to the SGR Repeal and Medicare Beneficiary Access Act of 2013. Section 2 repeals the Sustainable Growth Rate, or SGR, and provides for a new physician payment mechanism by providing for 3 years of payment updates at 0.5% through 2016, creating a new Value-Based Performance Incentive Program, or VBP, that consolidates and improves the 3 existing physician incentives programs beginning in 2017, and providing incentives for physicians to test being reimbursed through the development of new alternative payment models, or APMs. Section 3 seeks to improve the development of quality metrics for use under the VBP program, as well as the APMs, by maintaining those quality metrics that are already used by physicians, as well as providing new opportunities and funding for physician specialty organizations to develop new measures relevant to the care they provide. Section 4 provides new codes for physicians to utilize in the management of patients with chronic conditions. Section 5 seeks to improve the accuracy of physician payments through two mechanisms. First, the section provides the Secretary with the authority to collect information from physicians and other professionals regarding the cost and time of furnishing services. Those who do supply would be compensated for their supplying the data. Second, Section 5 provides a target of 0.5% of the total physician payments over 4 years for reducing overvalued codes. If the Secretary, in consultation with the RUC, meets these targets, these payments can be redistributed within the existing physician payments. Otherwise, the funding is removed from the payment pool. Section 6 requires the use of appropriateness use criteria program developed or endorsed by physician specialty organizations for advanced imaging through clinical decision support mechanisms. Section 7 approves the data available to beneficiaries on the Physician Compare website, but ensures that physicians are able to review and correct the data before being publicly reported. Section 8 expands the Qualified Entity Program, or QE, to allow QEs to make their own analysis and Medicare data available to physicians as part of their quality improvement activities. Also, this section requires that Medicare data be made available to clinical data registries, which are often maintained by physician specialty societies. Section 9 provides an opportunity for physicians who opt out of Medicare to do so once, as opposed to the current requirement to do so every 2 years, provided they remain out of the program for 2 years. This section also requires HHS to develop a new pilot program for non-participating physicians. Section 9 also requires that HHS certify by the end of 2017 that electronic health records are interoperable, or provide specific recommendations to make them interoperable. Finally, this section specifies that the development of any quality or clinical guideline in Medicare cannot be construed to establish a standard of care or duty of care. With that, Mr. Chairman, my walkthrough is complete.
Thank you. Are there any questions for Mr. Sutter? Yes, Mr. Neal is recognized.
Thank you, Mr. Chairman. I have a question that's technical in nature, but I think it's much underreported, Mr. Sutter, and your response would be appreciated. The legislation before us today builds on reforms that are already underway in our healthcare system to root out inefficiencies and reward value over volume. These efforts have contributed to a slowdown in healthcare spending and an improvement in the financial outlook for the Medicare program. Emphasis on what is happening. A recent report from the Council on Economic Advisors found that healthcare spending growth is the lowest on record. According to the most recent projections, real per capita healthcare spending has grown at an estimated average annual rate of just 1.3% over the 3 years since 2010. This is the lowest rate on record for per capita healthcare cost growth in any 3-year period, and less than 1/3 the long-term historical average stretching back to 1965. The CEA report also finds that healthcare price inflation is at the lowest rate in 50 years. Thanks to this slowdown in spending growth rate, CBO has reduced its projections of future Medicare and Medicaid spending in 2020 by $147 billion, a 10% reduction in projected spending in these programs. These projections show that the recent slow growth in healthcare spending has substantially improved the long-term federal budget outlook. I ask for unanimous consent to submit for the record a recent report from the Council on Economic Advisors on trends in healthcare cost growth.
Without objection, the report's submitted into the record.
Now, Mr. Sutter, would you agree that the reforms in this bill before us today are similarly focused on encouraging better value in our healthcare system? Reference particularly to what is happening with the slowdown in healthcare spending and on Medicare in particular.
Yes, sir. What this bill tries to do is build on both the public and private interventions that have reduced the spending, and it does so through creating a strong foundation of quality measures, resource use measures, meaningful use requirements, and focusing on clinical practice and improvement activities, all areas that are key in result in reducing healthcare expenditures and maintaining those lower healthcare expenditures.
Okay. resulting in the lower use of hospital and other services and perhaps the more efficient use of the mix of Medicare services?
Yes, sir. In fact, in the bill, there's a MedPAC report that looked at the physician involvement in lower Medicare spending overall. Those reports are to be issued in 2016 as well as 2019 so that we can take this into account in the future as well.
Thank you. Mr. Chairman, much of the back and forth and some of the rancor that we've all experienced in the chamber over the last couple of years has caused, I think, this story to be underreported as to what's really transpiring on the health care front, and particularly in terms of the longevity of the health care program. So thank you.
Thank you. Mr. Kind.
Thank you, Mr. Chairman. Mr. Sutter, thank you, for your work on this. It's my understanding that already under the Affordable Care Act, there's a value-based modifier that CMS has been working to implement. Implementation initially was going to be 2016 and then ramped up from there. As I read this legislation, as I understand that value-based modifier, it is now being absorbed into the current legislation, so it would make redundant what CMS is already. Is that your understanding as well?
Yes, sir.
Okay. Also, it's my understanding, reading the legislation, Mr. Chairman, that there's no consideration of extenders with the legislation before us today. Is that right, Mr. Sutter? We're not dealing with extenders with this package before us?
Correct. They are not in this text.
Right. Mr. Chairman, I like the direction that this legislation is going. I believe it's long overdue that we continue to drive the health care system to a place where value and quality and outcomes is rewarded rather than the current fee-for-service model that merely reimburses based on the volume of services and care that's rendered regardless of the consequences. And this, I think, is an important step, right step in that direction. And as this process moves forward, we'll have time to continue to work on other items, such as the extender policies, which is vitally important, obviously, to rural patients and rural providers. And I know we've enjoyed bipartisan support in trying to address that in the past. That's not being addressed with. But I have one additional concern as well. And Mr. Sutter, it's my understanding that under this legislation, there's going to be the availability to get Medicare data for analytic purposes as far as cost efficiency and overall efficiency in the system. Is that right?
That's correct, sir.
But that data is only going to be available through one web portal for analytic purposes. Is that right?
Correct.
Well, in my home state, Mr. Chairman, again, in my home state of Wisconsin, we have what's called the Wisconsin Health Information Organization. This group, it's a national leader in health analytics, exchanges, and remains an invaluable source of information for people in the healthcare industry working to improve transparency, quality, and efficiency of healthcare. Within this bill, it's a good starting point for qualified entities such as this to be able to receive and disseminate the Medicare data. There is some concern, however, that the access limited to just one portal is going to limit the private subscribers' ability to be able to accumulate this and do their own analytics with it. So maybe as we move forward, we can keep an option open of how we can make this available to these entities, such as the Wisconsin Health Information Organization. We can talk about de-identifying the data, deal with some of the anti-competitive issues that do arise, limit the group subscribers that would be available to do the analytics. We could talk about data use agreements or even monetary penalties with the misuse of it, but I think by limiting it to just one web portal, it could limit the ability of groups like this who have already been doing this within our own home states to be able to do this in a much more efficient and much more meaningful fashion. I think it's an important feature of this legislation that that data is available so we can get to best practices, protocols of care, what's working and what's not, and hopefully as we move forward we'll have a chance to do that. But I'm encouraged with the direction this legislation has taken. I think this is an area of healthcare reform that there has been bipartisan support in the past. I know Dr. Frist, when he was serving in the Senate, and even today, has always talked about moving to a value-based reimbursement system. This legislation continues to take us in that direction, and I think it's a good starting point for the conversations to continue. And with that, I'll yield back.
All right, thank you. I'll go to Mr. Roscom and then Mr. Becerra. Mr. Roscom's recognized.
Mr. Chairman, I'd like to enter into a colloquy. Mr. Chairman, Medicare loses close to $60 billion each year in fraud and improper payments. No one denies this. In fact, some have even a higher number. As we look forward to tough decisions that must be made to strengthen and protect Medicare for future generations, one obvious issue to address is the current antiquated system of paying out claims only later to go back and look for fraud and improper payments. Together with a bipartisan group of members in the House and Senate, I've helped put forward the Preventing and Reducing Improper Medicare/Medicaid Expenditures, or PRIME Act, legislation that improves the way CMS operates and works to apply the great successes of the credit card industry in preventing fraud and abuse. As I've noted before, Medicare loses close to 10% of what they take in to fraud and improper payments. By comparison, the credit card industry loses only 0.044 of their almost $17 trillion in transactions. Today, my colleague and partner in this effort, Senator Carper, plans to offer the PRIME Act as an amendment to the other body's SGR proposal, and I'm hopeful that the chairman will agree to work toward this, to include this common ground solution in any long-term SGR fix legislation that the committee moves forward in the future. And I yield back.
Well, I would just say to the gentleman, obviously these issues, trying to combat fraud and abuse has always been a priority of this committee, and this is an important policy area, and I think it's one that I appreciate the work that you've done on it and look forward to trying to address this. We're making some fundamental changes to the Medicare physician payment system in this legislation, and we need to make sure that we avoid any unintended consequences. And so, especially in a program such as this, or any federal program, frankly, which is vulnerable to fraud and abuse. So I look forward to working with you on that legislation as we continue to move this process forward. Thank you. Mr. Becerra.
Thank you, Mr. Chairman. And let me say thank you to you and Ranking Member Levin for the bipartisan work that produced this legislation. Mr. Sutter, quick question. There are many Medicare and Medicaid programs that Congress typically extends at the end of each year alongside this SGR doc fix, right?
That's correct.
Among those would be extenders such as the therapy cap exceptions, which ensure that beneficiaries receive medically necessary therapy services, and the qualified individuals provision, which helps modest income beneficiaries afford the cost of physician visits. Both of these valuable programs, as well as other more targeted provisions, generally are extended with this SGR doc fix each year. The SGR short-term patch, in fact, that's on the floor today does extend for 3 months these expiring extended provisions. Mr. Chairman, I want to also note that the Senate Finance Committee is actually marking up their version of the SGR legislation, which includes a long-term fix to these extenders as well. I just want to point out that we need to figure out a way to come up with a solution that extends permanently these provisions, which are indispensable to many Americans. Therapy caps, if a lot of Americans found that they would be cut off from being able to afford that therapy service, we'd probably end up paying a lot more money in the long run. And the qualified individual provision, which makes it possible for a lot of seniors in America to actually be able to afford to go to the doctor and not have to make a decision between paying their rent and getting their medical services is also very crucial. And so I know that the work will be done on these, and I just wanted to place on the record that I hope that we can have as much success in moving forward on those extender provisions, which typically run alongside with the SGR doc fix, as we've had so far in coming to terms bipartisanly on this issue of finally fixing the SGR provision. With that, I'll yield back, Mr. Chairman.
Thank you. Dr. Price, and then Mr. Doggett.
Thank you, Mr. Chairman, and I too want to add my commendation to staff and Mr. Sutter and others who've been working so diligently on this. I have a couple specific questions, and I've got a lot of them, but a couple that I'll share today. On page 9, it was referenced earlier, the value-based performance incentive program. Could you expand more on the three main programs right now, electronic health records, PQRS, and VBM, how they're being rolled up into this one?
Certainly, sir. So you are correct that under the VBP there are 4 categories: quality, resource use, EHR, meaningful use, and clinical practice improvements. Quality measures and use currently in the PQRS system are included in this. We do make some modifications to allow for the development of additional quality metrics. Resource use uses those metrics currently in the value-based modifier. though there are additional changes to the current methodology that we do, as well as making alternative mechanisms for physicians to report on their specific role in treating beneficiaries. EHR meaningful use continues through. However, we also, to prevent duplicate reporting, professionals who report quality measures through EHR systems are deemed to meet the meaningful use requirements, so hopefully reduce redundancy in that program. And then the new section is clinical improvement activities, which enables professionals who are already performing such activities to receive credit, also encouraging activities that hopefully will lead to future participation in APMs. And the menu of those activities will be established in collaboration with those professionals. And importantly, those activities must be attainable for both rural, underserved, and small practices.
This version doesn't envision that the resources available for this new model. There are no new resources coming available. It envisions utilizing the resources that would be available under the previous programs, EHR and PQRS alike. Is that correct?
Correct.
There's a lot of concern about, as the physician community, about non-medical people making medical decisions, and a lot of there are many areas in the bill where I have some concerns. Page 27 highlights a couple of them. We're talking about weighting activity and how you determine whether or not somebody gets a bump up or a bump down. Some of this language talks about a performance category based on the extent to which the category is applicable to each eligible professional. Further down that page talks about outcome measures. Who's determining these, or who's defining what these things are based upon this version?
Well, we would hope to engage the physician specialty societies through a notice of annual call for quality metrics. This is something that the agency does now. We are codifying that to bring that in. But ultimately, at the end of the day, the secretary is the one that's going to have to make sure that those are applicable within the existing or within the program.
There's some concerns there, obviously. Page 30 talks about the alternative payment model. Many folks in the fee-for-service arena, especially in the rural area and in small practices, are we preserving the ability to continue in a fee-for-service model if that's what works best for a physician and patients?
Certainly, sir. I think we've tried to identify that the APMs don't work for everybody, and certainly Medicare APMs are not available in all areas. We also recognize that a lot of physicians are doing work with private payers so that they have a mechanism to get into an APM if they want to. However, we certainly do think that the reforms made to the existing programs help those physicians that do want to remain in fee-for-service.
Thanks. And one final question on page 39 talks about the performance funding pool. This is the new pool that would be available for the VBP. It says that the money comes from the current fee schedule. So again, just to stress, this is not new resources coming in. This is all money that's currently within the reimbursement formula and payment system for physicians caring for seniors.
Correct.
Thank you, Mr. Chairman. I yield back.
Thank you. Mr. Doggett.
Thank you, Mr. Chairman. Both our healthcare professionals and their patients deserve the long-term peace of mind that a permanent replacement of the broken sustainable growth rate policy would bring as approved by the committee today, not the uncertainty of another stopgap 3-month extension that the House as a whole will approve today. And while I'm pleased that some progress is being made in developing actual legislative language to implement genuine reform, the changes in this system are not free. Nowhere in today's action is there any suggestion of how to pay for more than $100 billion of cost to fix this system. Indeed, there has not even been bipartisan discussion of payment. Instead of figuring out how to pay for the first $100 billion, last-minute changes that our Republican colleagues have made in the last few hours have added about another $8 billion of unpaid costs to the bill. Like funding for our broken national transportation system, we can usually achieve bipartisan agreement about the need to spend money in this Congress It's just when you try to figure out how to pay for it that bipartisanship breaks down, as it has totally broken down on funding our transportation infrastructure. I am absolutely in favor of a permanent fix, but not if it is financed by borrowing more money from the Chinese, or by undermining the Affordable Care Act, or by imposing significant new cost on our seniors and disabled. It is not by accident that the public could be confused by what is happening in Washington today. On the floor of the House, an emergency stopgap measure for the next 3 months, much like the emergency stopgap measures that have been approved one year after another, is being adopted. In the House and Senate committees, a permanent answer without financing is being adopted. The approval of one does not necessarily mean that the other will be approved. Without a clear mechanism to fund this measure, it is not at all clear whether today's action represents more than a symbolic victory. I yield back.
All right, Mr. Paulson is recognized.
Thank you, Mr. Chairman. I just want to thank you and Ranking Member Levin and Subcommittee Chairmans Brady and Ranking Member McDermott for all of your work on this issue as well, especially as now we move closer to that permanent solution that is stable, that begins to move us to a system where we pay doctors based on quality, not quantity, and that is efficient for both doctors and patients. I'm also really encouraged that the proposal now includes language that is very similar to the bipartisan legislation I introduced with Congressman Matheson to utilize clinical decision support, those tools that will help share those best practices, improve clinical outcomes, reduce costs from unnecessary testing, and improve patient safety. And it does all this while protecting the doctor-patient relationship. Mr. Chairman, there is obviously more work to be done, and as Mr. Becerra had mentioned earlier, I know that the extenders are not included as a part of this markup, and they still do need to be addressed. Some of those are very important to many constituents that I have in Minnesota, including the therapy caps and the cost contracts. I just respectfully ask that you continue to work with the members of the committee and act on those important issues as the bill moves forward and we have a final product that moves to the House floor. Thank you, Mr. Chairman.
Well, thank you. Just as by way of comment, obviously the Medicare extenders are very important, and we plan to address them as we move this bill to the floor. But like the Energy and Commerce bill, which did not address extenders, we're following that really to try to move forward on the SGR replacement policy and get that policy right. But getting this first step forward is critical. Obviously, the Medicare extenders will be another step along the way. Mr. Blumenauer is recognized.
Thank you, Mr. Chairman. I appreciate this represents some potential significant movement forward. I like moving in parallel with our friends in the Senate, the work with the Energy and Commerce Committee. I am not unmindful of some of the concerns raised by our friend from Texas, but I am hopeful that as we move forward, taking advantage of this time, we can zero in on areas that are frankly not partisan, where there are significant areas of savings to extract more value out of our healthcare system. Many of the features in the Affordable Care Act actually have been bipartisan agreements over time implemented by Republican and Democratic governors. I agree with Mr. Roscom. I'm proud to co-sponsor his bill. Our friend, Mr. Gerlach, I've been pleased to work with him on the Medicare Common Access Card, which I hope we can dive in and accelerate over time. I think there's a great deal of value to be extracted that will help. It's no secret that I have been working with this committee on dealing with end-of-life care and making sure people understand what their choices are and that those choices are respected. Not only will that provide higher satisfaction, but it will, in the long run, actually reduce costs and improve patient self-determination. I would have hoped that in this we would have been able to have some additional help to make sure that patient preferences would follow across state lines in an era of electronic records. I appreciate the reference to telehealth. This has significant opportunities to dramatically reduce cost and improve care. It's in the underlying bill, it uses it as an aspect of care coordination, but it basically is relegating it as a matter of further study. And I would hope, Mr. Chairman, as we move forward, that these would be two areas, in addition to the legislation by Mr. Roscom, Mr. Gerlach, where our Health Subcommittee and the full committee can zero in on things that will provide tangible benefits, reduce costs, and deal with this longer-term problem without shortchanging either providers or patients. I appreciate what this represents and hope that we can move forward on some of these specifics in the weeks to come. Thank you, and I yield back.
Thank you. Ms. Black is recognized.
Thank you, Mr. Chairman, and I want to thank Mr. Sutter and the Chairman of the Health Subcommittee, Mr. Brady, for the work that you've done. It's been a lot of heavy lifting, and yet this is an important subject, and getting permanent solutions here will certainly help our doctors and ultimately our patients. I want to focus today on an area, the ambulatory surgical care centers, or ASC setting of care. I'm concerned about these professionals who practice in different settings, like the ASC, that may be penalized for failing to have their own electronic health record system. And I would like to work with you and the committee to include a solution for this predicament as we move forward on the SGR reform. In my district alone, I have 16 of these ASCs. And as you know, under the Stage 2 of the EHR incentive program, CMS defines a meaningful EHR user as an eligible professional having 50% or more of outpatient encounters at locations with the certified EHR technology. And in the case that physicians have a significant number of patient encounters in the ASC, this requirement may really be difficult to achieve as there is no certified EHR technology for these settings. And so I am concerned about that. I hope that we can work on a pathway to assist them. And as we move forward, I would like to be able to have this as part of the conversation.
I appreciate that comment. I certainly I know Mr. Sutter will work with you on that, and I will as well. I think this is an important issue. There's always room for improvement, and I think this is an area that we can take a further look at.
Thank you, Mr. Chairman.
Any comment, Mr. Sutter, on that?
We attempted to address some of this in the underlying bill by having physician only be assessed on those things that are relevant to them. However, as you mentioned, these regulations for physicians that perform a lot of services in the ambulatory surgery centers could get a payment reduction, and we will certainly work on that.
Mr. McDermott is recognized.
Thank you, Mr. Chairman. For 10 years, well, actually since 2005, the OIG has been issuing opinions about whether gain-sharing arrangements between doctors and hospitals or whatever are okay. It's been done on a case-by-case basis, and one of the things that worries me as we push toward alternative payment methods is that everything is done case-by-case because we have not developed the regulatory rules and shared savings arrangements that healthcare providers would give them certainty about what they were doing. I think one of the things we're all worried about is there's a lot of money here. And whenever there's a lot of money, then we talk about fraud, waste, and abuse. And part of that is because we don't make our rules clear. And what's troublesome in here, Mr. Chairman, the only thing I see in this bill that affects or that relates to this is at the end of Section 2 where it says there is a study going to be done about the potential fraud potentialities of APMs. Is that, they're supposed to give us a report in 6 months? Is that correct?
Yes, sir. We attempted to address it in two different ways, a study on new fraud vulnerabilities within APMs themselves, but also to have the Inspector General offer specific recommendations to the point you made on gain sharing It is a very complicated area, but we need to get further feedback directly from them on what's feasible and how we protect that going forward.
I think they've offered suggestions already. We never had hearings on this issue. I really think it should have been done before this bill passed, but we're beyond that now. And I really think that the other section that worries me a little bit is, tell me how much more authority you're giving to the Secretary of HHS to approve these arrangements.
So we're not changing the authority per se. However, we are setting specific guidelines for what those APMs need to do in order to receive the bonus. However, there is some language there about other demonstrations in the future that might qualify as an APM.
So there's some looseness that can go through the Secretary's office on this whole issue because there's rules written into the bill?
It's the existing authority, but we do make a reference to other future demonstrations that might qualify, that do offer some latitude to the Secretary that.
And they would qualify on the basis of the OIG saying that one's okay. Is that right? They'd present their plan to the Secretary, she'd send it to the OIG, and then it'd come back and she'd say, okay?
I believe so. I'm not certain on the actual procedure there, but that sounds like that could happen, yes.
I mean, Mr. Chairman, my concern here is, in part, as a physician, I don't want patients to be hurt by our way of saving money. And it's possible that people may figure out ways to save money that really deny care to people that they ought to have. So I'm concerned that these rules be pretty clear so everybody knows what they're doing. Because we'll set ourselves up for a whole bunch of questions raised about why did such and such a thing happen? Well, it's because they got a grant, they got a waiver from the Secretary or someone, and that's what's troubling me here. And I think it's an issue that we have to come back on. We get a report in 6 months. I think you ought to schedule a hearing today so that we actually look at that report and see what it says, because I think you're going to find some interesting things.
Did you want to make a further comment on that, or did you?
No, we're happy to talk to Mr. McDermott further.
All right. Mr. Reed.
Thank you, Mr. Chairman. First of all, Mr. Chairman, congratulations on the work you and the staff have done on addressing the SGR situation, and I look forward to supporting this legislation. However, one of the issues my constituents have flagged is low Medicare patient volume for providers who do not treat a majority of Medicare patients, especially obstetricians and gynecologists. It is important to ensure the quality components built into the value-based payment program take this into consideration. As such, I would seek unanimous consent to introduce a letter from a constituent physician of mine dated December 10, 2013, and associated with the American Congress of Obstetricians and Gynecologists into the record that describes this issue in more detail, and look forward to working with you in regards to the same.
Without objection. And clearly, obviously, making sure that we have the valid and reliable statistical information is going to be important, and obviously certainly for all quality measures that are tied to that. So I look forward to working with you as we move forward on this legislation. Mr. Crowley.
Thank you, Mr. Chairman. With all indications that our country will soon face a significant doctor shortage, we need to look at steps to ensure that we're producing and retaining qualified doctors. Part of that is ensuring a stable payment system for doctors, and today's bill is a good step forward towards that end. But it also means making sure there are resources for our medical schools and teaching hospitals to train the next generation of physicians. That means addressing the issue of how many residency slots are available for our medical school graduates. And I have legislation, I know my colleague Ms. Schwartz has legislation, several of my colleagues have legislation on this issue. And I look forward to working with the committee and with them in moving that legislation forward. But we can also, it cannot cut graduate medical education funding, particularly when it's time to develop offsets for this bill. And I hope my colleagues all recognize this fact as we move forward. We need more docs, not less. And with that, I yield back. Thank you, Mr. Chairman.
Thank you. Mr. Griffin and then Ms. Schwartz. Mr. Griffin's recognized.
Thank you, Mr. Chairman. I want to thank you and Chairman Brady and the staff for all the great work you've done, particularly to responding to the issues my constituents raised when the first draft came out. My constituents were particularly concerned about freezing payments, and you've addressed and provided a positive update in the transition period. Requests from my constituents were also made regarding electronic health records and radiology services such as 3D imaging, and the Ways and Means language has been responsive. I appreciate your continued efforts, Mr. Chairman, and I look forward to continuing to work with you and staff on further issues such as 3D mammography and others. Thank you, Mr. Chairman.
All right, thank you. Ms. Schwartz.
Well, thank you, Chairman Kemp, and really pleased to see this legislation move forward. So my thanks to the chairman, to the ranking member, to the head of the Health Subcommittee, Chairman Brady, and to Mr. McDermott as well, and for all my colleagues who really have been very, very engaged in what has been a very serious discussion over the last several years about repeal of SGR and moving forward on new payment reform under Medicare for physicians to ensure improved quality, improved efficiency, incentives for value over volume, and to really move our system of payment, physician payment, forward. Many of you know that I've been working on this for several years, introduced legislation in the last session, bipartisan legislation in the last session, and introduced it again in March. Been working actively with engaging physicians and hospitals and other providers, as well as advocates for Medicare beneficiaries, to make sure that we not only repeal the SGR, but in fact create a new model for the way we pay physicians that does incentivize improved outcomes, improved quality, incentives for meeting clinical protocols and best practices, making sure that individual seniors and all those covered under Medicare get the very best care they possibly can. And at the same time, we incentivize efficiency and reduce duplication and rid ourselves of unnecessary costs and make sure that we improve health outcomes for those served and getting care under Medicare. This is what we're doing today. We're moving this forward in a way that it could truly transform the way we pay physicians in this country. There are many models in the private and public sector that are doing this already as payers, and Medicare should be a leader in incentivizing our physicians and healthcare providers to be able to encourage that quality, improved care, improved outcomes in this country. So this is a very, very important step forward as we really, again, create that stability and assurance for our seniors that they will have access to their physicians, and create that stability for providers, physicians, and certainly in hospitals, employ many physicians, to incentivize them to provide that quality and to be able to use the tools that we have, including the data, including the way we reimburse physicians, to improve the way they provide care. There are models around this country in both the private sector and in the public sector where we're seeing everything from bundle payments to ACOs to patient-centered medical homes, and all of those are making a difference, both in containing the rate of growth and costs, and of course, most importantly, getting health care to seniors in our country in a way that is cost-effective, accessible, and meaningful to them. So I'm proud to be a part of this discussion and to have played my part in leading the way in really setting forth a framework and legislation that I introduced again in both this session and last session. I do want to acknowledge my colleague in this, Joe Heck, not a member of this committee, who stepped forward to make sure that it was bipartisan legislation, and to all of the many stakeholders in this process who embraced a new way of being reimbursed that would incentivize quality and efficiency and improve care, contain the rate of cost for taxpayers, and ensure quality for our seniors. So this is a good day. Look forward to working in a bipartisan way, bicameral way, which I've been doing, to make sure that this legislation gets done. I don't think we have to take all 3 months, Mr. Chairman, if we can help that in providing that security and certainty for both our seniors and for a medical community in this country, so that we can begin the process of transforming the way we pay physicians and getting the right kind of care to our seniors. So thank you. Proud to continue to work with you to get this done in the next few months.
All right, thank you. Mr. Brady's recognized.
Thank you, Mr. Chairman. First, I want to commend you and Ranking Member Levin for the work that you've done in bringing, after 15 years, a real, authentic, reliable solution to how we reimburse our physicians. This is about our seniors and the growing number of physicians who can no longer afford to treat them within Medicare. This is about Republicans and Democrats in a very unusual environment in Washington, all advocates for our seniors and physicians coming together to find that right solution. I want to commend, there's so many, but I want to commend Congresswoman Schwartz for her early leadership of this. I commend the members of our doctor caucuses, Dr. Bustani, Dr. Price, and Diane Black, who've been compelling advocates for an early market updates in the early years of this transition that I think will be important to our local physicians as well. A couple quick questions. Mr. Sutter, does this bill finally end the 15-year flawed formula that has driven so many of our physicians to rethink their relationship with Medicare, including many who unfortunately can no longer see new Medicare patients?
Yes, sir. It repeals the SGR.
Do we ensure that local doctors no longer live in fear of a drastic cut for their services every New Year's Day?
Yes, sir.
Do we replace that annual cliff of cuts with a new, permanent, reliable floor from which discussions in the future about health care will be about improving the system rather than merely avoiding a catastrophe?
Yes, sir.
And then finally, do we begin the hard work of streamlining the red tape that our local physicians and healthcare providers struggle with as they deal with Medicare and how they treat our seniors?
Yes, sir.
Mr. Chairman, this may not be the final step. This is a very important step forward. I know it's not the end result, but this is an important step ensuring our seniors are no longer searching for a local doctor to treat them when they're ill, and I commend the work that you have done in this. Yield back.
Thank you. Mr. Davis. And I believe that's the last speaker I have seeking recognition, so Mr. Davis is recognized.
Thank you very much, Mr. Chairman. I, too, want to commend and congratulate the committee, and especially your leadership and that of the ranking member, as we move forward on what I consider to be a very major issue. Given the fact that my congressional district has 24 hospitals and 4 medical schools, as well as a large Medicare population, this is indeed huge for us. And so I also want to associate myself with the remarks made by Mr. Crowley, especially as we look at physician need and especially as we look at the formulation and creation of slots. Medical practice is so important that family physicians, I think, is an area where we must seriously consider. And so I commend the committee. I wish the term was longer. I also would have hoped that we could have included or considered before we leave for the holidays unemployment insurance, but this is a big step forward, and I commend you, Mr. Chairman, and the committee.
Thank you very much. There being no further questions, are there any amendments to the amendment in the nature of a substitute? Dr. Price.
Thank you, Mr. Chairman. I move to strike the last word.
Gentleman's recognized for 5 minutes.
Thank you. I want to, again, commend the staff and commend Chairman and Mr. Brady and others who have been working on this vital issue. The SGR history has been remarkably troubled, and it's a Washington solution that clearly doesn't work. I'm hopeful that as we move forward, we don't come up with another Washington solution that doesn't work. There are significant concerns that remain, and I ask unanimous consent to include in the record 2 letters, one from the American Academy of Orthopedic Surgeons and one from other surgical specialties, including the neurologists or the neurosurgeons and the anesthesiologists, expressing their concerns.
Without objection, the letters will be placed in the record.
Dr. Bustani and I have been working diligently with staff, and we appreciate and the chairman to move this forward. We continue to have significant and fundamental concerns. The period of stability that is offered in this piece of legislation is 3 years, which is good, but there are many surgical specialists who say that 5 years is an absolute minimum to be able to incorporate and move toward any transition model. There are real reservations that we have about expanding the authority of CMS. Clearly, the Affordable Care Act has demonstrated in vivid relief that there are major shortcomings with government-run health care, and we don't believe it's appropriate to expand the role of CMS. Many areas give us pause. As formerly practicing physicians, we understand that medicine is a collegial activity, and that's how people get the highest quality of care. In some areas, we have concerns about pit physician against physician, and we look forward to addressing those. At its core, quality health care rests on a trusting relationship between patients and families and physicians. And some portions of major proposals, not just this one, but others that have been floated on the Hill and even been passed in other committees, we believe may potentially violate and make more difficult that trust. Quality health care, what's right for any one individual may be what's not right for another individual based upon quality, even if they have the same diagnosis. Having Washington define quality in specific ways for each patient, we believe, endangers unique individual treatment and endangers real quality. And to that end, Mr. Chairman, I ask unanimous consent to insert into the record there are 5 different articles from the New England Journal and elsewhere about value-based purchasing and the like that
without objection.
speak to that. More needs to be done in that area. I mentioned fee-for-service earlier, and in many ways, oftentimes fee-for-service, especially in subspecialists, it seems to be the best method for financing care, and we believe that it's important to preserve this option as a priority as we move forward. Have a lot of other concerns, but this day is a real opportunity. Recent score from Congressional Budget Office of $116 billion to repeal the current SGR formula over a period of 10 years is an opportunity. Docs have been used as pawns in this system, and it's not only unfair to physicians, it's been unfair to the patients of this country. The current system is an absolute failure, and if we're this close to being able to repeal it, we ought to seize that opportunity, so long as what we put in place is better than current law. As we move forward, as I mentioned, Mr. Chairman, this is the next step. I think it's important for people to appreciate that with Energy and Commerce having acted and with Senate Finance acting, that the only way the Ways and Means ideas and the benefit that we bring to the table, that we have an opportunity to affect the final outcome, is to move forward today. And so I encourage us to do so. As with all of us, any future support is obviously dependent on future progress, but I look forward, Mr. Chairman, to continuing the good work that's been done and further positive improvements. And I yield back.
Well, I thank the gentleman. I would just say that I'm committed to working with all members of this committee as we try to make this SGR repeal a reality next year. We all have an important role to play, and especially as we get into the difficult discussion of pay-fors. But we do need to resolve this issue once and for all, for seniors, for physicians, for taxpayers, and I look forward to working with all of you to do that. If there are no further amendments, I will now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move the committee favorably report H.R. 2810 as amended to the House of Representatives.
The question is on favorably reporting the bill. All those in favor signify by saying aye.
Aye.
Those opposed signify by saying no. The ayes have it. The motion is agreed to. Recorded vote is called for. The clerk will call the roll.
Mr. Johnson?
Aye.
Mr. Johnson, aye. Mr. Brady?
Aye.
Mr. Brady, aye. Mr. Ryan?
Aye.
Mr. Ryan, aye. Mr. Nunez? Mr. Nunez, aye. Mr. Teaberry? Mr. Teaberry, aye. Mr. Reichert? Mr. Reichert, aye. Mr. Bustani? Aye. Mr. Bustani, aye. Mr. Roscom? Aye. Mr. Roscom, aye. Mr. Gerlach? Aye. Mr. Gerlach, aye. Mr. Price? Aye. Mr. Price, aye. Mr. Buchanan? Aye.
Really?
Mr. Buchanan, aye. Mr. Smith? Mr. Smith, aye. Mr. Schock? Mr. Schock, aye. Ms. Jenkins. Ms. Jenkins, aye. Mr. Paulson. Mr. Paulson, aye. Mr. Marchant. Mr. Marchant, aye. Ms. Black. Ms. Black, aye. Mr. Reed. Mr. Reed, aye. Mr. Young. Mr. Young, aye. Mr. Kelly. Mr. Kelly, aye. Mr. Griffin. Mr. Griffin, aye. Mr. Renacci. Mr. Renacci, aye. Mr. Levin. Mr. Levin, aye. Mr. Rangel. Mr. Rangel? Mr. Rangel, aye. Mr. McDermott? Mr. McDermott, aye. Mr. Lewis? Mr. Lewis, aye. Mr. Neal? Mr. Neal, aye. Mr. Becerra? Mr. Becerra, aye. Mr. Doggett? Mr. Doggett, aye. Mr. Thompson? Mr. Thompson, aye. Mr. Larson? Mr. Larson, yes. Mr. Blumenauer? Mr. Blumenauer, aye. Mr. Kind? Mr. Kind, aye. Mr. Pascrell? Mr. Pascrell, aye. Mr. Crowley? Mr. Crowley, aye. Ms. Schwartz? Ms. Schwartz, aye. Mr. Davis? Mr. Davis, aye. Ms. Sanchez? Ms. Sanchez, aye. Chairman Camp?
Aye.
Chairman Camp, aye.
The clerk will report the vote.
39 ayes, 0 noes.
There being 39 ayes and 0 noes, the motion is agreed to. H.R. 2810 as amended is ordered favorably reported to the House of Representatives. Without objection, staff is authorized to make technical and conforming changes to the bill. Without objection, members will have an additional 2 days to file with the committee clerk supplemental, additional, or minority views. So ordered. There being no further business before the committee stands adjourned.
Good job.